Mammography is regularly used for the early detection of breast cancer, and women are already getting this, so how about maybe a twofer? We're looking at investigators who are asking whether this might be a novel approach to screen for coronary artery disease. And to talk about this, I'm with Dr. Jagat Narula, who is an MD, PhD, and a professor of medicine, specifically cardiology, and a professor of radiology at Mount Sinai Hospital. And my favorite title, the editor-in-chief of JACC Cardiovascular Imaging. This is a fascinating paper, and you're one of the co-authors of this. What's the background? What's the story that got you to do this paper?
Rick, this is well known that breast arterial calcification has some relationship with coronary artery calcium. Although we do know that the mechanisms of the calcifications of breast artery versus coronary arteries is quite different. In breast artery, it is more of a medial calcification. On the other hand, in the coronary artery, it is more of a neointimal calcification. So although the mechanisms are different, there has been a relationship which is quite well known to the investigators for a long period of time. We have been having this ongoing collaboration, specifically Dr. Harvey Hecht from the Department of Cardiology at the Cardiovascular Institute at Mount Sinai, in collaboration with Dr. Claudia Henschke and Dr. David N. Kelowitz from radiology department, and we have been having this ongoing collaboration. And as you know, last year in the ACC, we also presented the impact of the passive smoking and the coronary artery calcium with the same group. And this time came in Dr. Laurie Margolies from our breast cancer center, who actually is an expert on the mammography and the breast arterial calcifications. And so we collaborated with her as a part of our ongoing relationship with this team. And the results have been quite encouraging.
So specifically, how many people did you evaluate and what did you find?
So basically what we did in this particular study was that we had looked for the people who had mammography as well as the availability of their CT scans of the lungs. These are the ungated CT scans. So basically, again, I mean, here it gives us another important limitation of the study, because this happens to be quite a biased population. So whenever we will be discussing the results of the study, there would be some selection bias involved there. So one important thing is that we have got the digital mammography in there, and on the other hand, which has a much higher sensitivity, and on the other hand, we have only those people who have got the CT scans available for their lung, suggesting thereby that they had some other conditions where the CT scans of the lungs were needed. And these conditions could obviously be cancers, they may have been smokers or other infections or other lung conditions, which all put them at a higher risk of having a coronary artery calcium also. So with those limitations, I think we should discuss the study. So people who had mammography as well as who had the availability of CT scans, so that we could compare the presence of coronary artery calcium with the breast arterial calcification. So in this particular study, what we find is that out of all our subjects, approximately 40% of them, that is 2/5 of the population, had an evidence of breast arterial calcification, which is higher than what we normally see or what is available in literature. So 40% of them having the evidence of breast arterial calcification, and then of them, up to about 50% of them, 47% to be specific, had an evidence of coronary artery calcification as well. Okay? And this all could be said with approximately 70% of diagnostic accuracy. So the implications of this study are significant when you look at it. In spite of all these limitations that we are talking of, you know that there are approximately 37 million mammograms are done in the country every single year. Of those, even if we take a very conservative estimate and we say that 40% is a very high estimate and we should come down to about 10%, which is about where the literature is.
That's what the literature says.
So if it is about 10% there, you are talking of approximately 3 to 4 million young women who have an evidence of breast arterial calcification. And if 50% of them are likely to have the coronary artery calcification associated with it, and again, it's an overestimate,
right.
You are talking of approximately 2 million young women who otherwise may not have had any other clue or would not have even subjected to any kind of risk factor scoring or obviously no directed screening.
It's time to get some risk factor scoring.
Essentially. I mean, I'm not going to go ahead and say that all these women should go for a coronary artery calcium scan or anything like that. But what I'm trying to say here is that this has a value which probably exceeds that of the risk factors and adds on to the Framingham risk score or the pooled cohort equation that we calculate in these people. So essentially, we would be able to get a clue that this is the time that we should at least start telling them about the behavioral modification or lifestyle changes. Right. That doesn't hurt us. I'm not going too far here. Right? I'm not trying to suggest extra test. Right. I'm not trying to suggest anything extra, but I really want that their physicians, whether they are the primary care physicians or it is their gynecologists or whosoever it is, we basically should educate them that this is the time that we start talking to them, and it has got to be a comprehensive approach. It has got to be, all of us have got to get together towards the health promotion, health awareness and health education.
And this is a test that's already being done. So it would take advantage of technology that's already being used for for a different reason.
Very well said. I mean, it is an available information and this is a collateral information gain for us. So it is a clue which is available to you already and you should be able to take advantage of it, or in the other words, you better exploit it.
Yes, exactly. Well, in the editorial comment, Nasser and McAvoy write, in our viewpoint, the most implicating finding of the current study lies within the BAC's robust positive predictive value. That was the 70% you were mentioning, correct?
Right.
I mean, that's pretty impressive.
I wish I had read Khurram's editorial, because this paper was handled by the guest editors. Since I am the author on the paper, yes. So I am not privy to the information in terms of who the reviewers are. I know Khurram has written the editorial, and that too came to me through these interviews that people said that Dr. Nasser has written the editorial, and I know he's a very astute cardiologist, an amazing thinker. So I do believe that he must have put it into perspective, which we should be able to read today. Exactly. When the paper goes online.
Now, what's needed now? Where from here?
Well, again, as I said, that I'm not going to go too far, at least at this point in time, essentially because the data are not prospective, number one. The second important thing is that there is a significant selection bias in this population.
Correct.
So because of those limitations, I'm not going to go and start making recommendations at this point in time. The only thing I'm going to say is that it is time that, since we do not have any directed or so-called advanced screening test specifically in women, specifically in younger women, we should take advantage of whatever is available to us if it has been shown. Right. Whatever be the underlying mechanism, if it has been shown that there is some relationship in one kind of calcification in one kind of arterial bed with another kind of calcification in another arterial bed, we should take advantage of it. So, well, can this be, can this lead to recommendations in terms of we need to do more tests? I think it all will depend if similar studies come forward, or if we design a proper prospective study in this particular area, or there even could be another way of doing it. Say, for example, if the best arterial calcification is present in one mammogram, next year when you repeat, or 2 years later when you repeat the mammogram, should it straight be a CT scan? Right. Which can give us the breast arterial calcification, which can give us the coronary artery calcification, and if there was any reason to believe, like the patient was smoker for a long period of time, and there is a guideline-based appropriate use of a CT of the lungs also for finding the nodules, this might accomplish all the things in one go. So there are ways to do that. I think we'll have to all get together. It's the time that we should be getting together and creating a comprehensive approach to the diseases. And we should be looking forward to the health promotion in a more complete or a holistic way, rather than just going by, that is my area of research and it is yours.
Exactly. Right. And this is in JACC Cardiovascular Imaging. Congratulations. This is a really fascinating paper.
Aren't you looking at a good journal?
I absolutely love it. And the paper is Digital Mammography Screening for Coronary Artery Disease, and it is online as of you looking at this. And what issue is it going to be in? Do you know yet?
It is in the April issue. Okay. Which is released with the American College of Cardiology. Right. On behalf of American College of Cardiology, do not forget to look at the JACC Cardiovascular Imaging issue of April. It is Cardiovascular Disease Imaging in Women. Oh, all the articles, wonderful original contributions, as well as 6 beautiful state-of-the-art reviews, including the imaging vignettes, editorials and everything all about the cardiovascular diseases in women. There is another paper which is coming out today it is in embargo until today, from Dr. Pam Douglas as a post hoc analysis of her PROMISE study. Oh, yeah. That is in there. There is another paper on the optical coherence tomography in stable coronary artery disease in women, which tells us that when you look at a stable disease, it is no different than men. So let's stop making all these distinctions when it comes to the coronary artery disease, and we have got to get our act together and go after the coronary artery disease in women as aggressively as we have done in men.
Well, it's good advice, and please read more about it at JACC Cardiovascular Imaging. For CardioSource World News, I'm Executive Editor Rick McGuire.